Should public health communication be honest? Should it be ethical? Or sometimes is non-honesty justifiable on public health grounds? Hello, my name is Martin Lipscomb and I'm talking to Dr. Rebecca Brown, a Senior Research Fellow at Oxford University's Uehiro Centre for Practical Ethics, about an excellent and highly readable paper that she wrote with Dr. Micheal de Barra of Brunel, London, titled A Taxonomy of Non-honesty in Public Health Communication. In this work, Rebecca and Micheal argue that many forms of professional communication are potentially unethical. The paper is about public health. However, the work has a great deal to say to the way nurses communicate with patients and their families. This is an important paper. It presents arguments nurses ought to consider. Links to Rebecca and Micheal's work are provided in the notes, along with, of course, a link to the paper being discussed. And now, without further ado, please, Rebecca, hello. Could you outline your argument? How and when does public health communication veer towards being unethical?
Hi, thank you. Thanks for the introduction. I'm glad that you read and enjoyed the paper and thought that it was saying something that was kind of important or interesting in some way. So how and when does public health communication veer towards being unethical? Well, I think there are lots of different ways in which public health communication could potentially be unethical. What we have tried to do in this particular paper is really focus on the question of honesty and look at ways in which public health communication might deviate from honesty. So we take honesty, a kind of an initial definition of honesty from a philosopher called Christian Miller, who defines it as reliably not intentionally distorting the facts as the agent sees them, which is a bit of a mouthful. But what it's trying to get at is the idea that, an honest person tries to communicate things in such a way that people form true beliefs about those things. So you're not intentionally distorting the facts. You're not trying to create distorted beliefs in the person that you're communicating with. So in order to be honest, that's what you should be living up to. So what we've looked at in this paper is a number of really common public health communicative practices or tools that we think look slightly dodgy from the perspective of honesty. So we don't try and argue that public health communication must always be honest. We kind of assume that probably most of the time it should be honest, that this is likely to be a desirable feature of public health communication, but we don't make the kind of stronger claim that it definitely must always be honest. And then we try to show how these really common ways of communicating public health information look like they might not always be the right side of the kind of honesty, non-honesty divide. So again, we're not trying to argue that they're definitely dishonest, that they're definitely unethical, but what we're really trying to do is encourage a bit more reflection and consideration of what seem like very, very common public health communicative practices, and ones that are never really or rarely seem to be questioned. So they're just kind of taken for granted. And there's kind of an interesting discussion to be had about the ways in which public health communication differs from communication in clinical contexts and the requirements of those two different forms of communication. And certainly from an ethical and a legal perspective, the requirements are very, very different. So if doctors fail to get informed consent from patients before they perform invasive interventions, then, in theory at least, they're liable to charges of assault and battery, whereas it seems like public health communication can get away with providing information which is very, very sketchy and yet could lead people to make really significant changes to the way they live their lives. And there's there doesn't seem to be any formal rules against doing that. Like there's absolutely no informed consent requirements when it comes to providing public health information. So we want to kind of highlight how really common practices look a little bit dodgy, and to try and encourage a bit more reflection upon those practices by people who are working in public health communication and perhaps other areas of health communication as well. So just to give a few examples of the kinds of things that we flag in the paper. So we talk about things like omitting relevant information, which could include something that we call harm neglect. So it looks like when public health communicators are describing the benefits of interventions like weight loss interventions, kind of dietary or exercise or smoking cessation. It's typically these kind of behavior change interventions that they're recommending. They will spend a long time outlining the benefits of these kinds of interventions, but they'll often leave out the harms altogether, or they'll get kind of less of a mention, it's less prominent. And so we call that harm neglect. So it's just this kind of imbalance in how, in what information is presented. Another one that we came across, we named outcome swamping, which is where you get this really long list of all of the bad things that could possibly happen if you don't engage in behavior change. So obesity is a case where this seems to be particularly common. So in describing the harms of obesity, you'll get this really, really long, you'll get like a paragraph of the risks of obesity without any indication given of the relative likelihood of experiencing those different kinds of risks. They'll do things like name every single different cancer that obesity increases your risk of developing separately. And so it looks like what's happening there is you're kind of hitting people with all of this, like there's this bad thing and this bad thing and this bad thing and this bad thing and this bad thing, and you're not kind of encouraging some kind of accurate understanding of really what the risks to your health and well-being are, but instead you're being perhaps just kind of scared into action to some extent. We also describe one of the most important ones, I think, that we talk about is mismatched reporting. So this is a communicative practice where the formats in which risks are communicated differ depending on whether or not you're communicating a benefit of an intervention or a harm. And so what you tend to get more use of relative risks in the context of health communication. So risk information will often be communicated in the form of, exercise will reduce your risk of heart attack by 50%. So it cuts your risk in half, rather than saying exercising regularly can reduce your risk of heart attack from 1 in 10,000 to 1 in 20,000, which would be the same information but presented in a different way. Now, relative risks tend to be big numbers and they tend to seem very impressive. It's often a doubling or a halving or something like that, whereas the more transparent way of communicating that information is as an absolute risk or as a natural frequency. So the natural frequency would be something like going from 1 in 1,000 to 1 in 20,000. But the absolute risks or the natural frequencies are much less impressive, typically. They're much smaller. So lots of health information tends to be communicated in relative risks, and this is because they're often communicating the benefits of a health intervention. And what we see is when the harms of an intervention are actually communicated, that's often provided as an absolute risk. So that's often provided as a small number. And so you'll get things like talking about screening programs, where the benefits of the screening program will be reported as a relative risk, but the harms of the screening program will be reported as an absolute risk. So what you're doing is you're kind of exaggerating the tendency to inflate the expectations of benefits alongside kind of reducing the tendency to pay attention to the expectations of harm. So I hope I've explained that reasonably clearly, but basically there's this kind of what looks like a slightly sneaky way of managing to kind of exaggerate benefits and minimize harms at the same time by using the format that you describe risks in a particular way, and that gets referred to as mismatched reporting and is surprisingly common in communication of public health interventions. So we don't think that these kinds of practices are necessarily going to count as failures of honesty, or that they're necessarily dishonest. One reason it's particularly hard to make the case that this is dishonest is that when we think about what dishonesty involves, we normally think there has to be some kind of intention to deceive the recipient of the information. And I don't know what's going on inside public health communicators' heads. I don't know what their intentions are. And it's possible that they don't see themselves as distorting the information in any way. They see themselves instead of as presenting it in ways that do help people understand it accurately. So it's possible that these kinds of practices are not dishonest, but nonetheless, they look like they're worthy of greater attention and consideration as to whether they're justified, whether they are presenting people with an accurate understanding, whether they're actually improving the accuracy of people's beliefs, or whether they're sacrificing the accuracy of people's beliefs in the service of achieving some kind of behavior change that the public health professional has decided is worthwhile.
Thank you for that outline, really interesting. Before I read your work, I was aware of some, but certainly not all of the problems identified in the section of your paper labelled Public Health Communicative Practices. However, as I read the paper, I found myself becoming increasingly annoyed. The ills you identify are, in my view, quite pernicious. It's surprising they don't get more attention in the literature. Your work addresses a very serious set of disturbing practices. Now, regards the paper, I have a comment and also a question for you. My comment involves others. The paper was brought to my attention by my friend and colleague Paul Snelling, and in turn I've shown the work to several clinicians. Now, their responses were quite interesting. Some people were defensive. Others suggested the forms of communication they engaged in, for example, emphasizing relative rather than absolute risk data. These forms of communication are, they say, sometimes defined or set by others. Your paper doesn't explore these issues in depth, albeit that you do allude to kindred matters towards the end of the work. Nonetheless, I think the idea that people don't have agency or complete agency regards the nature of communication is intriguing. I tend perhaps naively to assume that it's in my power to determine whether or not I give, for example, full information, but perhaps that's not always the case, or not always necessarily the case in a straightforward sense. However, that comment aside, my question to you is, if a nurse or other healthcare professional read your paper and agreed that what they did when providing health information to patients and their families was sometimes not as ethical as ideally they'd like it to be, must they immediately address all and every point you raise, or are some forms of unethical practice, assuming that's what it is, more serious than others? Is a hierarchy of wrongs contained within the practices you outlined? And if there is, in your view, what ought healthcare professionals to concentrate upon first?
Yeah, so I think with these things, there are kind of gradations in wrongness. There are worse ways to behave. And so addressing those first seems like a good idea. And of course, it's hard to behave in the most ethical ways all the time, and to kind of regulate one's behavior ideally. So all we can really do is kind of strive here to put the work in to try and figure out what the right thing to do is, and then to enact that as best we can. So I think in the context of talking about things like honesty and communication, it seems like telling kind of flat out explicit lies that create in someone a completely false belief, purely in order to benefit yourself rather than the individual that you're talking to, is more wrong than, for instance, telling something like an altruistic lie, where that involves saying something that's technically technically not true, but which you think will actually create a true belief in the person. So for whatever reason, you think that they'll kind of be suspicious of what you say, so you kind of tweak what you say so that when they've done their little suspicious reinterpretation, they have a more accurate belief or something like that. So if your aim is actually kind of genuine in that way and you're trying to create a true belief, but in order to achieve that, you have to commit this minor wrong, which is to tell a technical lie, that seems less bad, right? And your motivations for that are kind of pure in some sense. So I think that our kind of the normal moral intuitions we have about this stuff kind of guides us pretty well a lot of the time. I take it that it's going to be fairly unusual for people to think that they commonly engage in wrongful, deceitful communicative practices. Like, I think most people probably think that what they're doing most of the time is pretty ethical and that they're well motivated and they're doing it, they're doing things for the right reasons. So what our aim has been is to try and encourage people to reflect upon whether or not some of the things that they take for granted are kind of ethical and acceptable really are kind of honest, really are kind of okay, or whether they're a bit more troubling upon reflection. So some of the things that we've picked up on, I think lots of people would initially think are benign, and then it's only when you present it in a certain light, or when you present it alongside an analysis of a concept like honesty, that it starts to look a little bit dodgy, or when you introduce the possibility that the motivations aren't quite so kind of honest or pure or something, then it starts to look a little bit more like it might be kind of unethical. So I think that one of my worries with this paper, and you just kind of flagged it there slightly, is that public health professionals or healthcare professionals more generally will become defensive and will kind of respond to this as if it's an attack on them, an accusation that they're being dishonest, they're kind of intentionally misleading people. And that wasn't really our intention. It was, we kind of came into this assuming that people are generally well motivated, and people who work in healthcare are presumably often just trying to do their best to make people healthier. And in some sense, their motivations are pretty good. But it's just whether or not they're kind of going about that in the ideal way, or whether they've kind of fully understood what the implications of their particular set of tools and techniques that they've been passed on through their training and practice are appropriate ones. So I think that attempts to kind of immediately defend some of these practices are sometimes driven by that kind of defensive-ness, rather than a kind of more reasoned consideration of whether or not this is actually the right thing to do. So the pushback that I've had on this has often been people saying things like, people won't pay attention if you only provide them with the kind of the absolute risks, or if you provide numerical risk estimates, then their eyes will glaze over and they'll kind of miss the point. It's clearer and simpler to provide relative risk, so it's more likely to kind of really get people to understand how important this is, or those kinds of things. And I think they believe that when they're saying it, but this isn't what we actually learn from people who work in risk communication. So people who work in risk communication, who kind of grapple with how best to present risk information so that people understand it and can use it in meaningful ways. They don't say, leave out the numbers. They don't say like, oh yeah, definitely don't provide people with numerical risk estimates. because that will just confuse them or put them off or something. They say the opposite. They say, like, do provide numerical risk information. And like one of the things we've found when we've looked at public health communications is they often don't provide any numerical risk information at all. And they also, risk communicators, risk communication kind of experts don't say, oh, be sure to provide relative risks, because that kind of helpfully makes clear to people how significant this is and avoids them underestimating the importance of this behavior change. No, they say use transparent risk formats, like use natural frequencies, so that people can properly understand how you're changing their baseline risk through this intervention. And they'll also, recommend making use of kind of pictorial representations and useful kinds of visualizations so that people can better understand the kind of risk information that they're being provided with. So I think we should follow that kind of expertise when we're trying to craft usable public health information. So I don't want to lay all the blame with the people who are immediately responsible for kind of doing the communication. So it would be great if when I show up for a cervical smear test, the nurse who's performing it is able to tell me, if I ask them, oh, if I attend cervical screening, every 3 to 5 years or whatever it is, over a 40-year period, how will that actually change my risk of dying from cervical cancer? Right, like that is the key. That's the information I need in order to know whether or not I should bother showing up for the smear test. Now, I think it's very unlikely that they would have that information available to them and that they'd be able to tell me that. And I don't think that's necessarily their fault at all. I think that's information that's actually like quite hard to get to some extent, and it's often just assumed that that's not something that patients will want to know or that they need to know. And I think patients have been kind of taught that they're not supposed to care about that kind of stuff as well, that they're just supposed to follow the recommendations, and the NHS says you should attend screening at this frequency between these ages, and you don't worry yourself about the details of that. Like we've decided that that's kind of cost effective and the best way to promote health, and we're the experts and you don't need to know about it. Well, I don't think that's really good enough, but I don't think that that's that whole system that's created that kind of an attitude amongst both the healthcare professionals and the patients is the fault of a single nurse, or is it, like it's not their fault. So I certainly don't want to lay the blame with kind of individuals who are operating within the system, but I want to kind of encourage them to think about, oh yeah, like this is kind of relevant information. How can I best present this to people in ways that is useful and meaningful to them? And often people will just want advice or guidance. Like they don't always want the kind of the nitty-gritty details to kind of reflect upon and make those decisions. They're quite happy with a healthcare professional just kind of saying, yeah, this is probably in your interest, you should probably do that. And that's fine. That's fine when that's what people want. But at the moment, the situation is that it's very difficult for people to get hold of more detailed information about these kinds of public health interventions. And the information that is available to them seems to be presented in ways that make it very hard for them to interpret it correctly. Like it seems often to be presented in ways that's intended to create a particular behavior change rather than intended to inform their behavior change. So our aim definitely wasn't to say, public health communicators, other healthcare professionals are bad people, that they're doing everything wrong, but rather to encourage a bit more kind of reflection and consideration upon their practices, upon their behaviors, upon the training that gets provided within those professions, in order to try and improve the quality of health communication in ways that's ethical.
Dr. Rebecca Brown, thank you for speaking with me about this paper. I recommend that everyone should read it. You present complex arguments succinctly and accessibly, and the subject matter is clearly relevant to nurses, in fact, to all healthcare professionals. I also note that you and Dr. de Barra have collaborated on other works tackling different aspects of this issue. And so anyone interested in reading further might check out that work as well as the one discussed here. Again, thank you for talking to me. It's been a pleasure.